Good morning. Thank you, chairpersons. Thank you, Professor Ranjan. It's an honor to be here. I guess a lot of it has already been covered as far as the critical care is concerned. I was there for the last couple of sessions, and a whole lot has already been done. Now, let me take you through a little story about acute ischemic stroke. Now, by and large, that's the largest stroke we have as in sheer numbers. And those of you who have not read the 2017 November Lancet, how many of you read this publication of 2017 Lancet publication from the Indian Council of Medical Research, the Public Health Foundation of India, the Ministry of Health? How many of you read this? None. Well, that has been a real eye-opener because it gives you the disease, the statewide disease burden of the, different diseases that we have in this country. Apart from everything else, ladies and gentlemen, in the northeast part of our country, the top cause of death is stroke. It's not maternal child health, it's not tuberculosis, it's not malaria, it's not cancer, it's not MI, it is stroke. Did any one of you know this? This is our country. Thank you. So every 20 seconds there is a stroke, and every 2 minutes we have a stroke death. So ladies and gentlemen, it's raining strokes, and 60%, 70% of strokes are acute ischemic events. So let's talk of that. So before I go further, there are two basic tenets that you understand about an ischemic event. Like every minute, every hour, there's a blocked artery which remains blocked. There's zillions of neurons which are lost irretrievably, and unless you have a magic panacea for all evils emerging from the horizon, you can't retrieve them. That's the first basic tenet. And the second is that amount of the critically perfused, jeopardized tissue, which Professor Ranjan has said, the ischemic penumbra, it's an enigma, but not sine qua non to what is picked up on a neuro imaging, but the duration of this structure depends on what has caused the stroke and what is the rate of spontaneous recanalization. So a whole lot of concept is now revolving around what is the code and what is the collateral status. It's as individualistic as your own fingerprint. That's the emerging concepts. Hence, the duration is not time clocked. Therefore, we pick up these patients using a tissue plate, tissue clock, and not on something which is time. So, because at the end of 3 hours, we don't have Cinderellas coming out of pumpkins or vice versa, right? So, we have moved away from that concept. So, in the current status, yes, you have all these guidelines which are there for you to know, and we are still in search of this, again, as I said, magic panacea, which is neuroprotection. That holy grail search continues. So, but then in the last decade, those interventions which have really moved how we look at stroke in general, from one of nihilism to one of hope and aggression, has been, yes, the thrombolysis. That's been a game changer, but that's the most glamorous part. And the whole of the country is now after mechanical thrombectomy. Yes, we have hemicolectomy, which does save lives, but I think of not talked about is a management of a patient in a dedicated stroke care unit. This is the unglamorous part. But believe me, that actually improves by 40% of a better outcome in an acute stroke patient, whether it's an ischemic event or a bleed. So, do you admit all your stroke patients? Well, no, certainly not Medanta or Apollo or Institute. So there are strict criteria as to who you should not let them go, but then we are guided by so many other things. But then this is also listed. Lab tests, in fact, we initiated this intravenous thrombolysis across the country, and all these things are not really there. These are useful for you to subtype for stroke prevention further, but then the most mandatory lab test would essentially be just one, and that's blood glucose, right? At a district level, I'm not getting into this whole thing about, big infrastructure. You're not going to get that. Maybe in Apollo. To some extent, maybe AIMS. Dr. Himanshu is sitting here, he knows what's the reality per se, but then for your acute care, the most important thing would be blood sugar. And of course, you also have the bleeding parameters depending upon the individual. So these guidelines in early management of patients, the latest is 2018, which are there by Powers. And then in the recommendation sessions, you do have the general supportive care, the emergency treatment, the in-hospital, and in fact, even out of hospital. How many of you know this Mission Delhi, which was launched a couple of days ago? Come on, this has to be an aware society. The Mission Delhi was launched in the institute 2 days ago by the Indian Council of Medical Research, and the Mission Delhi essentially is that now you're going to perform intravenous thrombolysis for acute myocardial infarction on the site. All right? Whether it is a roadside or it's in a shack or in somebody's home. Please be aware this is happening in your Delhi. All right? So these guidelines are all there. The reason I put this up is that now you're taking the acute care to where the home is or where the patient is. Why? Because time is brain, time is heart muscle, time is life. Isn't it? So there are 3 very, very time sensitive diseases in the universe. One is trauma, the other is heart attack, the third is stroke. Please remember that. So there are these guidelines. The reason I put them up is that they're all there. We're going to get into the detailed discussion a little later. The blood pressure management's again been touched about. There's nothing very humongously different between a management of acute bleed whereas acute ischemic stroke. The only difference is, so far whatever guidelines we have been based upon the last Interact 2 trial, which again probably has got into a little bit of controversy with the Attach 2 trial publication. So it seems that we have a sweet spot as far as acute bleed is concerned, that you definitely have to drop down immediately to 140/90, maintain there for the first 24 hours. Don't go beyond the 140. That's what Attach 2 told you. So you do drop down in an acute bleed, you don't maintain it at 180. In an acute ischemic event, you're maintaining it 180. All right? You're dropping it down to at least 180 in an acute ischemic stroke who you want to intervene in form of some kind of a reperfusion strategy, whether it's intravenous or intraarterial or mechanical thrombectomy. But in other situations, you maintain your mean arterial pressure above about 120. You need to do that because you have to keep your pressure, the what you call a perfusion head. I've never given clofidipine and all that. What we generally use is labetalol, which is on the shelf. It is free. It's 10 milligrams to 20 milligrams IV stat. We repeat it 10 minutes. The literature says you can go up to 300 milligrams. I don't think that's practical. Somebody not responding to 2 doses of labetalol, I'm not going to, continue with that. Either I start an infusion or I quickly go on to the other drugs. Okay. Now, the general supportive care. Now, this is a no-brainer. All of us know. A little bit about oxygen. Now, there's always been said that, there are 2 things that the public loves. What is it? एक तो saline लगा दिया, fluids लगा दिया, दूसरा oxygen लगा लिया, right? Very important. So it's an important placebo effect. But then when you're coming down to science, in oxygen, we've got studies on normobaric oxygen and hyperbaric oxygen. No evidence for hyperbaric oxygen. For normobaric, we were also part of the study groups. We published our data. We haven't found anything there. The reason for oxygen and the normobaric, hyperbaric were essentially to give you the time window for an intervention. It's extending the duration of an ischemic penumbra. You are actually preserving that jeopardized tissue, not getting it converted to an infarct. But that's not really borne out after the animal studies, even the NIH studies, after a point of time, they just stopped. So I don't think we have an evidence for a normobaric, certainly not for hyperbaric, but certainly you need to maintain the oxygen, the saturation at least 94 to 95%. So you're not dipping it down to 90 to 91%. The positioning. Now that's another thing very, very interesting. We've got the head post trial which is published. We were also part of the trial. As a logically, whenever you say an acutely ill patient, you don't want to keep them flat, would you? Because you're scared of aspiration. So those guys who are very critically ill, especially those who are in altered sensorium, you don't want to have them flat because they're aspirating their own secretions. Thereby, you would think that you need to position them a little bit elevated to maybe 30 degrees. 2 things. You're preventing aspiration. You're also probably trying to reduce the raised intracranial pressure. Said that, this head post trial, when they actually done, it's a massive trial. It's a huge trial of 16,000 patients and huge number of countries involved. AIMS was also part of the center. And then they had this, so it was a practical trial. So they didn't have to have very rigid criteria. So they could go on to this position within the first 24 hours. And it was based on a nurse practitioner. Remember, the ultimate actually delivery, a lot of it is the stroke team, as Dr. Ranjan really rightly said. It's not individual, it's a stroke team in which a nurse practitioner, stroke nurse, massive, humongous role. So they got this, so they had this, someone elevated to 30 degrees, maintained for 24 hours, henceforth, the others were lying flat. They didn't find any difference, but most of this inclusion into this head post trial were actually minor strokes. So it doesn't really make a difference. So my take home on this part of it, we don't know the answer yet, but logically, if there is anybody in altered sensorium, someone I'm scared that they're going to aspirate, someone I believe was going to get into raised ICT, I'm going to have them elevated, head elevated to 30 degrees. Okay, that should be the take home message. The one was thermia. We do have evidence that even 1 degree centigrade rise of any temperature will up your mortality by 10%. It's huge. So you're not going to get that happen. You give paracetamol around the clock, get that thermia down, and obviously prevent infections. Cardiac monitoring, I'll come. Now, BP, there's a whole lot of reasons why BP can go up. Someone who's not even hypertensive can do this, so it could be protective, it could be reactionary. And of course, there's a whole lot, and I think the biggest bugbear and controversy which simply doesn't seem to die down is how much to monitor, how to reduce, when to reduce, how much to reduce, and what drugs to use in an acute stroke, whether it's an ischemic stroke or a bleed. So it continues. But then we have our own, the experience with that, and as Dr. Ranjan, I would completely agree with him that this is the practice that we generally do. So these guidelines have largely not been touched. In an ischemic event, it maintains. And these figures really look bad. 220 systolic, I get palpitations when I look at these figures. But then that's how it is. Essentially, what it means is you're dropping it down too acutely in an acute ischemic event. You're transforming what is dying into a dead brain, and you don't want to do that. Said that again, quickly subtyping the stroke, Himanshu would agree on this, that we have the stroke protocol, we have a stroke. We quickly, not just, the image is just not parenchyma, we also have the pipe, so we know the subtype of a stroke. That gives you a great indication as to how much and whether you to reduce the blood pressure. Tell me one indication you don't want to drop the BP low down in an acute ischemic stroke subtype, it's large artery. All right? When you have a critical carotid stenosis, you're not getting them down to 140 by 80. Sorry, you're really going to be, it'll be difficult. And then, of course, wherein you definitely need to reduce the BP. All these are there. They've been there since 2013. Nothing's changed there. And the change in thinking is what Dr. Ranjan has already touched about. And antiplatelets, that's another thing. See, in the guidelines, you have aspirin given in the first 48 hours. We have 40,000 people data to say this. It stays. It certainly stays in your pre-hospital. It stays in your hospital. It stays in triage. Only it will not be given if you are contemplating a reperfusion strategy. And now a contemplation of a reperfusion strategy has gone to 24 hours. Yes, whether it is wake up, whether it is dawn diffuse 3. So our time has now gone beyond 3, 4.5, 6, 8, up till 24. So whenever you contemplate of an acute reperfusion, then don't give antiplatelets, otherwise you go ahead. No role for any other antiplatelet, and certainly not the newer guys. It's even the ticagrelor, it's a Socrates, and even the Thales, that whatever, the Thales, we were part of Thales trial, it's not got published yet, but even in that subgroup, the ticagrelor group hasn't really done humongously well. So the anticoagulation, we know this, but then that's another thing which keeps happening to us, that if you do have a subtype which is a cardioembolic, you have an LV thrombus, or you have an actively fibrillating heart, and you know that this is the guy who's going to get into another stroke very quickly, and you want to get anticoagulation on board. That depends upon what is the extent of an ischemic event he's had. So it is the 2-6-12-day principle. In fact, we say 1-3-6-12-day principle, which has been borrowed down from the European Heart Rhythm Society, that if you have a very manual stroke, start immediately. You have a moderate, wait for a week or so, major strokes, at least 2 weeks. You can tell me when to stop, please. So the volume expansion, hypertension, vasodilatation, they're all there. We just don't do this. We're not giving hemodilution. And when there is a hypotension, again a no-brainer, get the BP up, but we're not actively doing it. All that are still in the research realm. The reason we haven't got this so-called neuroprotection is because this is what happens, ladies and gentlemen, after an acute ischemic event. The ischemic cascade is so complex. You have so many of these, targets you can intervene, probably. But look at these equations. The equations go perpendicular, they go tangential. And what's important here, glutamate, becomes bad here. So you stop it here, but you need it at a certain point of time. So either we have a bunch of drugs who can tailor all of them, or you have this magic bullet. And certainly we haven't come across it. Therefore, the Holy Grail chase continues. So no neuroprotectant approved, although Idaruvan is there in Japanese guidelines, and Citicoline and Idaruvan has been approved by CGI, like several other things which gets approved in this country. But there is really no evidence to say that. And all these things are there for you to see. So this search continues. ICT, I'm not getting into it. It's been really talked about in great length. But what we see in acute ischemic event is a hemicolectomy. We do this. It's a life-saving procedure. It is routinely being done. You need a friend who's a neurosurgeon. We do have friends, Himanshu, isn't it? Well, so therefore, you really need someone who is part of the team for that, because again, time is brain. You can't intervene once that thing is over. Hugely life-saving. There are little controversies, but a lot of them have actually been answered. So take home message, go ahead. Younger, we do have evidence till 60. Now we have the studies till 75 years, but it's be individualistic. There's nothing sacrosanct here. You have 80 plus guys who have ruled this country. So just don't go by age alone. So this mortality, if you don't do it in a malignant MCA, is big. You can prevent it by the surgery. And post-stroke epilepsy, somebody's already talked about it. Yes, it remains controversial. And again, I also agree with him when you say that there is this fear that you have this guy who's already critically ill, and I don't want a seizure happening on him on top of all that to offset all the balances. The checks and balances are really critical. But then these are the recommendations. But I think, the most important thing is the stroke unit, and this is no rocket science. Essentially, those individuals who are dedicated and who are there, who will pick up the early complications, prevent them and treat them. That's it. So the prevention of aspiration, DVT, fluid electrolyte balance, and early rehabilitation goes a long way beyond all these glamorous things that you can do. So the stroke unit monitoring, in fact, we have all these things here. We have our own Indian stroke guidelines. That's been published now last month from the journal that we have from the Indian Stroke Association. They've also been published in 2010. We have also updated them. They're going to come in near future from the Ministry of Health. So let me, swallowing test. How many of you know this protocol of swallowing test? Please, I need hands up. We are talking about a critical care. This is the most important thing, often neglected. You say you start off management, start feeding. The person who gives this order should know when to order this. And this is such a simple thing. Please know your protocol of swallowing test before you allow oral feeds to anyone or who's critically ill. The systemic complications, let me very quickly go through this. Have you heard of this thing? Takehome syndrome? It's interesting. It's actually an octopus there, because this resembles probably it's a stunned myocardium with any acute critical illness which is seen with acute bleed, with subarachnoid, with acute ischemic stroke. It's been documented. This is not often looked for, but one take-home message for all of you is, remember, autonomic nervous system has a different brain altogether. I don't understand this autonomic nervous system. It simply doesn't pertain to any rules. So when you have a right-sided insula affected, that has a very rich connections to your autonomic nervous system, all hell breaks loose. So those situations wherein there is a change in your trop levels, in your cardiac enzymes, there are changes on an ECG. These guys are prone to sudden death because of cardiac arrhythmia. That's Takehome. And it's actually a stunned myocardium. The risk factors being women, remember the insular region, the right insula. For some reason, that seems to be the hotspot. Pulmonary complications, somebody's already mentioned that. These are all the risk factors. But again, one quick take-home message is, have your oral hygiene good. That sorts of prevents a whole lot. And that's another thing we never bother. We expect the nurses to take care of the oral hygiene. And you just ask them to, you have this halitosis when you go near a patient, and and that's where the germs come in, they aspirate. So you take care of aspiration, positioning, oral hygiene, that's, in fact, half of your trouble would be over. But all these are risk factors which probably get on to aspiration, and the biggest killer we have in our critical ICU is infection, right? Then, so of course, these are the preventive measures, but one important thing is dental hygiene. There are oral antiseptics that we can use. Then the hypoxemia, well, all of these. I think, how much time do I have? 1 minute.
No, could you take more questions, because you've been
so I think the last one I want to mention here is the prevention of DVT. Even now, we don't use these stockings also. This is pneumatic compression stockings, but not the usual stockings. That's the last one. That also has become negative. But we can definitely use heparin pretty much more liberally, it seems. That that seems to be there. Okay, I think I'll just end here and we can take some questions.
Thank you, Dr. Padma. You obviously are a master of your subject, but you're a great public speaker. You've had everybody's attention, and now you can take a few questions. I'll start by, if I may not get a chance. If I've had a stroke, if I've had an MI and I'm on aspirin, 75, what are the chances of me having a stroke? So if I'm not smoking, I'm a diabetic, hypertensive, had a MI on aspirin, what are the chances of me having?
In an acute MI, there's definitive figures there, sir. In the first 24 hours.
2 years after my MI.
2 years after would be the same as any other risk factor, the bunch that we have. We have what is called as an ascent risk score, which are actually categorized into the age, the blood pressure, the diabetes, the heart disease, peripheral artery disease, smoking, and et cetera, and all those things. So you, according to ascent risk score, you can have that. Also the event happening, probability. So these heart risk scores have been done by both the WHO and the others. In fact, they're also there in our Ministry of Health guidelines. I hope you'll never have this. But then, it's certainly the risk is there. Not so much. If you really want me to quantitate, just that would be around 10%. It's big enough to be there. But then, when you add on AF, you add on something else, even if it's a paroxysmal AF, that's upping. The more important thing here is that you need to subtype. So my stroke preventive strategy will go beyond an antiplatelet. That becomes mandatory, and I think it's crucial, especially when you have a cardiac thing.
Okay, thanks. Can we have other questions? You finish your question.
You have suggested that thrombolysis is a new coming up therapy in the management of ischemic stroke.
It's not new. It's there since 1995.
But in cerebral cases, earlier it was used in the...
Acute ischemic stroke, sir. I don't want to hear this again. It is an established intravenous thrombolysis, has been approved in the year 1995, came into India in 1996, approved by Government of India in 2006. It's there at district level all across the country and free of cost. It's in the guidelines. Don't even say it's emerging. What's been come now into the 2018 guidelines is that we've extended the time window period. The other is other reperfusion strategies which are quickly coming on board more extensively. We've gone beyond solitaires now. That's what when I said it was mechanical thrombectomy. IVT established, not emerging.
Ma'am, we have seen in the cardiology this that's coronary thrombolysis is common being prescribed and it's being done. But after that, we are only achieving TIMI-3 flow only.
I understand. So when you
how percentage or how better can the cerebral thrombolysis be sure whether we have achieved the whole success?
You said that's what I'm saying is it's an old story. We've got tons of literature on this, and we also have the diameter of arteries which can be lysed when you give intravenous, and bettering it by other reperfusion studies. But just like you have a primary angioplasty, we haven't got a primary angioplasty as far as an ischemic event is concerned. But then everything else, we got documented literature which Dr. Ranjan, probably a truckload of literature we have on
Ma'am,
that.
can we go for the
We
directly
have
to
some
the
more
can-
questions from the audience, please.
I think Dr. Padma has been so vehement and clear, as such always she is. Everybody who's sitting here has to go with that message that thrombolytic therapy is the well therapy for the treatment of acute ischemic stroke. One point, if Madam allows me to make, is that we didn't know, does TPA increase the survival of the patient and does it increase the quality of life? There's recently a study where they followed up these TPA patients for 10 years, and it came in stroke recently, that TPA even increases your functional improvements and survival up to 10 years. So you've got evidence to say that also now. So please remember that, as Dr. Padma is very clearly said, it is not a therapy which is plus minus. It is a therapy which is there, which is there, which is there.
Thank you very much. We close the session for
There's one lady who's
Okay,
been
one last
standing for
question
a long
because
time.
already we are behind time.
No, I've seen there's a lady there who's standing for a long time.
Thank you. That AIMS has
That,
launched.
that's a mission Delhi, but that's for acute MI.
That's only for MI. That's what I was very sad to hear. I mean, there was no mention of anything other than MI.
That's okay. There's a beginning. That's always. You should always look at the brighter side of things. Okay.
Thank you very
Thank
much,
you.
both the speakers, Dr. Padma and Dr. Juneja. It was a wonderful session. Over to the organizers.
It's great, mate.